Hello, everyone. I'm Jeff Szer, a haematologist from Melbourne, Australia. I'm delighted to have been asked by the Academy to speak to you today on paroxysmal nocturnal hemoglobinuria. Where do we stand? Where are we now with this ultra-rare but fascinating disease? When I was a medical student, PNH was this. It was thought that patients hemolyzed at night, got dark urine in the morning, didn't hemolyze during the day, and so the urine lightened during the day. We now know this not to be true, and the dark urine in the morning is simply due to concentration of urine overnight, a normal physiological process. The history of this disease is fascinating. Some will know that it has been called Macchia-Favre-Michelli syndrome, and was thought to have first been described in the early part of the 20th century. But thanks to this wonderful review by William Crosby in Blood in 1951, we've been reminded that, in fact, Paul Strubing, a German physician, described this disease perfectly in the late 1800s, although his name doesn't appear anywhere in the taxonomy of this disease. Nevertheless, PNH, Paul Strubing, and a disease that we now know much more about, even after the expert clinical descriptions over 100 years ago. This is a disease of chronic intravascular hemolysis that results in a number of clinical consequences that are both impactful on survival as well as on morbidity and quality of life. You can see a sort of outline of the pathophysiology of this disease, which I'll describe in a little more detail as we go through. But the major clinical consequences are not anemia as such, but thrombosis, renal failure, pulmonary hypertension, abdominal pain, and dyspnea, each symptom of which independently contributes to the excess mortality seen in this condition. Also, there are features that are impactful of variable significance on the patient's quality of life. Fatigue is certainly in there, along with dysphagia, hemoglobinuria, and erectile dysfunction in males. The basis of all of this is intravascular hemolysis, and central to some of the pathology is the adsorption and subsequent reduction in blood levels of nitric oxide caused by the presence of free hemoglobin in the circulation. As a disease, it is rare, described as ultra-rare, and it lives within the bone marrow failure syndromes, as you can see on this Venn diagram, with a large overlap with aplastic anemia, a small overlap with myelodysplastic syndromes, in particular the low-grade myelodysplastic syndromes, and a small overlap with some myeloproliferative neoplasms. Of course, the overlap with those malignant conditions means that an acute myeloid leukemia phenotype may evolve in some of these patients. While there is a big overlap with aplastic anemia and pathophysiologically it is understood that PNH is actually unlikely to emerge as a clinical entity except in patients who have an aplastic focus in the background, enabling the expansion of these clones with a gene mutation. Along with this overlap with traditional immune aplastic anemia, you can see there is no overlap with inherited bone marrow failure syndromes, and this has been an observation that has been almost universal. It does have a significant impact on survival, with a third of patients dead within 5 years of diagnosis without modern treatment. And you can see a survival over 25 years that's far from attractive for sufferers. It is a progressive disease, so while the underlying pathophysiology is now understood, the process is ongoing and chronic, and complications do occur, increasing with time in a cumulative sense, resulting in a progressive reduction in survival and increase in symptomatology. You can see the peak onset of this disease is in the most productive years of life, and so that it is something that is well worth diagnosing at the appropriate time and coming in with effective therapy before irreversible complications can occur. The underlying mutation is of the PIGA gene located on the X chromosome, as I'll show you on the next slide. These mutations, these acquired mutations, result in the inability to bind important proteins to the surface of cells, and the important proteins in this condition are CD55 and 59, which are normally anchored by the GPI anchor protein, and their absence results in a failure of defense of the cell membrane against the always-on complement attack, resulting in intravascular hemolysis and the downstream effects which I've already described. PIG-A itself is located on the X chromosome, but the disease only requires a single mutation in order to result in the phenotype that we see, because of lionization of the other X chromosome in females. There are many somatic mutations at many sites, some of which are insertions, some of which are deletions, and whatever they are, and there are many, many of them, they do result in a non-functional gene and the inability to synthesize this anchor protein, which is illustrated in this slide as these long yellow-colored structures, which have many, many proteins attached to them, but of importance to PNH, the anti-complement molecule CD55 and 59, more of which is to come. Complement, of course, is one of those things we all tried to forget, but we have to remember it again. It's a vital component and an innate component of our immune system, and is highly conserved from very primitive species. It may be activated by 3 different pathways, which all converge on what is called C3, the third component of complement. I'll show you that in a minute. And each of these pathways is driven by a variety of stimuli. The classical pathway, usually by inflammation, usually by inflammation, the alternative pathway by infection, and lectin by infection and other antigens. The complement system is always on. It is a chronically functioning system and is at the ready to be switched on even further in the event of what is perceived as an attack. And the reason we don't destroy cells under normal circumstances is that we have defensive mechanisms, natural inhibitors of complement, a couple of which I've already described, and those are the ones of importance in patients suffering from PNH. So here's the diagrammatic representation of the complement system with the lectin, classical and alternative pathways, all converging on C3, which is always switched on, has innate tick over, as it's described. It can produce a variety of end products, but C3b, as a result of activation, then drives C3 convertase, and as amplified, drives C5 convertase, producing what is known as terminal complement, the C5b to 9 membrane attack complex that does most of the cellular damage, and C5a, which is an anaphylotoxin, is responsible for other inflammatory phenomena and driving endothelial and white cells to become increasingly active. And both of these end products are inherently involved in the thrombotic focus in patients with PNH. CD55 and 59 are natural inhibitors of these processes that keep the cells safe in the context of the membrane attack complex presence, but in their absence, these end products of terminal complement can do what they were designed to do and result in cell damage and ultimately of importance for PNH patients, thrombosis. Now here it is in diagrammatic terms. You can see the presence of free hemoglobin that results from hemolysis caused by terminal complement, as well as activation of platelets by now unprotected action of terminal complement, contribute to thrombosis along with nitric oxide depletion, which is capable of which results in vasospasm, more or less. These, plus the direct result of complement interacting with the coagulation pathways, produces a multifocal hypercoagulable state responsible for much of the thrombotic consequences that we see in patients with PNH. And thrombosis is the most important clinical endpoint seen in patients with PNH to be avoided. And that's because it underlies most of the mortality associated in this disease. In fact, 2/3 of patients who die with PNH do so as a direct result of thromboembolic phenomena. All patients with PNH are at risk for thrombosis regardless of clone size. I will show that to you in another slide. And it's also independent of how severe other measurements of PNH activity are, including transfusion requirements and whether or not the patient is on an anticoagulant, as many of them have been historically. The thromboses that can be seen in PNH may be very common thromboses, like deep venous thrombosis in lower limb veins, apparently spontaneously, but also may be unusual, and a commonly described association is with portal venous thrombosis, as well as cerebral venous sinus thrombosis, and other unusual arterial thromboses have been seen, including strokes and dermal infarction due to cutaneous thrombosis. And you can see the impact on survival for a patient who present with thrombosis as their presenting feature of PNH. And ideally those diagnoses would be made earlier. The thrombosis, as I pointed out, does result from uncontrolled complement activation, and this becomes the most highly active predictor for venous thromboembolism that we know of on a per patient assessment. So you can see the relative risk of developing a thrombosis in untreated PNH is about 60%. You can compare that with factor V Leiden deficiency, and it is only 2 or 3%. While each of these is higher than the background population, the risk of a venous thromboembolism in a PNH patient is huge. Is certainly, as I pointed out, an important predictor for survival. I mentioned that any size of PNH clone does produce a risk of thrombosis that is in excess of the background, and these data from the South Korean PNH registry that were presented over a decade ago now demonstrated how important this cut point of 1.5 times the upper limit of normal of lactate dehydrogenase is, as while patients with a smaller lactate dehydrogenase rise still have an excess of thromboses of roughly tenfold the background population. You can see the higher risk associated with a higher clone size and lactate dehydrogenase level. So who should be screened for PNH? What should we do to try and avoid missed early diagnoses? A couple of groups 10 and 15 years ago attempted to formulate a guidance for the population. The International Clinical Cytometry Society, as well as the International PNH Interest Group, which I'll point out later, is working on revising these guidelines in the modern era, as these guidances were developed before effective therapy was widely available. Nevertheless, there are some rules that, if equally applied, would be very useful for patients. Anyone with intravascular hemolysis with hemoglobinuria or elevated plasma hemoglobin should be evaluated for PNH. Anyone who's hemolyzing and is iron deficient, has abdominal pain or known thromboses, or has associated cytopenias should be evaluated for PNH. Anyone with a Coombs negative hemolytic anemia should be evaluated for PNH unless there is an obvious underlying cause. And anyone with an unusual thrombosis, particularly if there's a hint of a hemolytic process around, such as an elevated lactate dehydrogenase, iron deficiency, should be evaluated. And the recommendation was that all patients who present with a Budd-Chiari syndrome or splenic or splanchnic thromboses should be screened for PNH. Bone marrow failure is an absolute indication for PNH assessment unless it is a known congenital syndrome of bone marrow failure. Standard diagnosis is now made using high sensitivity flow cytometry. This has been standardized in most laboratories in the world, and I'm pleased to say it's very well done and very well reported by most laboratories, at least those whose output I've managed to see. The principle is still the same. At least 2 cell lines assessed for the deficiency of GPI-anchored proteins. Granulocytes are an important constant. That should be the one done every time, and at least 1 other cell line, such as monocytes or red cells. Red cells are probably the least quantitatively accurate because those are the cells that are destroyed, and the most seriously affected cells will not be available for assessment. So we move on to treatment, which many find the most interesting aspect of the modern world around PNH, and I certainly have found this to be a fascinating ride and a continuing ride. I'll focus firstly on the first therapy that was developed, eculizumab, which was a largely humanized engineered monoclonal antibody against the 5th component of complement, which, as you know, is, or as you've seen, is the bit that terminal complement and the damaging products of complement arise from. So this is showing where eculizumab binds in this more blocky description of the complement cascade, at least from C3 down. And you can see blockade of C5 and a prevention of cleavage of C5 removes the membrane attack complex while leaving proximal complement activity intact. The activity of eculizumab was described in a beautiful series of trials, largely driven by Peter Hillman. Initially a pilot study after he became aware of the existence of this molecule, and unlike the developers and the scientists who were responsible for thinking that a complement inhibitor might be clinically useful, he saw an immediate application in the most complement-directed disease of which he was aware, and that was PNH. So a pilot study was done in 11 patients with universal improvement of hemolysis in all patients, and published in the New England Journal of Medicine now 19 years ago. Rapidly, a placebo-controlled randomized study was set up, at the time the largest such study in an ultra-rare disease population. This was a placebo-controlled study in over a 26-week period, which we'll see described in the next slide. And then subsequently the Shepherd trial, which is a phase 2 study in a broader population of patients who had worse underlying bone marrow function and also might have had less transfusion requirement than was required in the trial study. These 2 studies and the pilot study patients fed into a long-term extension study, which has been published a couple of times and showed stability of the effect that I'm about to demonstrate. In parallel, there was a smallish phase 2 study in Japan called Aegis, and you'll see that the results of that study were identical to what was observed in the Western population. And that is what was observed. You can see the slides, the graphs other than the yellow dots showed all patients receiving active therapy had a rapid reduction in lactate dehydrogenase that was close to 10 times the upper limit of normal at the beginning of the study, down to near normal levels, although most of them were slightly higher than the upper limit of normal. The placebo group in the randomized study, you can see, remained unaffected as far as hemolytic activity and lactate dehydrogenase level was concerned, but rapidly joined the rest of the patients after the first dose of active agent was added at week 26 when the patients turned over. So PNH is characterized by chronic intravascular hemolysis with some acute episodes that may be driven by a variety of factors, some of which we'll discuss in the next couple of minutes. But you can see here another stylized version of the complement pathway. This time, factor B and factor D appear in the diagram. These are external controlling molecules of the proximal part of this complement cascade at C3. And I'll talk about these a little bit more later when we get into the therapy a little bit more. But you can see how this passage produces C5 and the membrane attack complex, which does nothing to normal red blood cells, but does lyse red blood cells that do not have a defensive shield. Although when one blocks the development of this terminal complement product, the membrane attack complex, no intravascular hemolysis is seen. What is seen is the binding of C3 now upregulated and no longer driving C5 cleavage. C3 can now deposit on these non-hemolyzed cells, and those cells become visible to the reticuloendothelial system and may produce a phenomenon of extravascular hemolysis. Intravascular hemolysis may break through C5 inhibition and may break through C3 inhibition, as we'll come to in a minute. The symptoms are the same symptoms that one sees in patients with PNH. Thromboses are a theoretical risk with breakthrough intravascular hemolysis, although the exact risk of a brief period of breakthrough hemolysis is unknown and may be lower than suspected. We suspect that it is breakthrough intravascular hemolysis based on the return of symptoms and signs and laboratory features that are consistent with a primary diagnosis of PNH in a patient who has had those symptoms, signs, and laboratory features controlled on eculizumab, or the newer version of eculizumab, ravulizumab, which is a further C5 antibody with different characteristics, allowing it to be delivered in much less frequently. So it's given at 8 weekly intervals rather than the 2 weekly intervals that is standard for eculizumab. And you can see from the randomized trial which compared ravulizumab to eculizumab in the early part of the study that excursions of C5 outside the normal range, the controlled range in patients on treatment, are seen not infrequently in the eculizumab group, but are never seen in the ravulizumab group, suggesting that the inhibition of C5 down to low levels is much more consistent with ravulizumab, perhaps because of more appropriate dosing of the inhibitory molecule than was used in the eculizumab trials and subsequently in the post-marketing environment. So breakthrough intravascular hemolysis in a patient on C5 inhibition may be due to pharmacokinetic breakthrough caused by inadequate levels of the antibody, or pharmacodynamic breakthrough caused by something that upregulates complement beyond the control that we had achieved with the C5 inhibitor at the time. When breakthrough intravascular hemolysis occurs, we can either watch and wait while we treat the underlying condition, depending on how severe it is. One can try to modify the dose or the frequency of administration of the existing C5 inhibitor, but that is quite difficult in most markets in the world. Or if available, one could seek an alternative C5 inhibitor, a number of which are in development, but none yet universally marketed. So in patients on eculizumab, the therapy with which we have the longest experience, the EBMT attempted to define a response criteria table for these patients based around the development of normalization of hemoglobin or not, elimination of transfusion dependency or not, normalization of the lactate dehydrogenase, and whether or not there was a reticulocytosis present. And with those parameters, one could determine whether we were dealing with with true failure, or possibly due with the development of extravascular hemolysis, resulting in persistent anemia and transfusion dependence, but while the intravascular hemolysis has been well controlled. So it's worth, as we move into newer therapies, it's worth knowing that most patients on C5 inhibitors are happy with their outcomes. There is a minority, but it's a significant minority of patients who either develop symptoms again or continue to have symptoms which are disturbing, and fatigue would be the major one. And in that case, we become much more closely aligned to the hemoglobin level than we were in the primary diagnostic and therapeutic space. So if the reticulocyte count is elevated, the lactate dehydrogenase is under control, and the bilirubin might be elevated, one should consider extravascular hemolysis as a cause. There are additional possibilities, and they're listed over in this bottom right-hand blue box, but bone marrow failure would be the most significant one that needs to be excluded, and the reticulocyte count can be very helpful. What is the problem with extravascular hemolysis, apart from anemia? Well, it might be ongoing transfusion dependence in a situation where hemoglobinuria is no longer relieving the body of an iron load, with the theoretical development and actual development in some patients of iron overload. Nevertheless, extravascular hemolysis does not need treatment in all patients, and it really is an individual patient assessment to work out what is clinically important. So what is the degree of anemia? How does that relate to symptoms? Is there an ongoing requirement for transfusions, and has iron overload developed, or is it likely to develop? And they're the sorts of questions that need to be asked about in patients on a C5 inhibitor, either eculizumab or ravulizumab, with ongoing anemia. So we know that eculizumab and ravulizumab have been very good at improving transfusion requirements and hemoglobin without normalizing either for all patients. It has been extremely effective in reducing the thromboembolic event rate down to a negligible number, and so the impact on survival is both predictable and now confirmed. It improves renal function, it improved quality of life. We saw that in the randomized trial, and as I pointed out, it almost certainly improves survival. But it has not improved underlying bone marrow failure. It doesn't change the rate that clonal evolution to hematologic malignancies might occur, albeit that is a very low rate. And it doesn't help every patient, in particular those who develop extravascular hemolysis where the help may have occurred and then been lost or never fully realized. And there are also those few patients, largely confined to the Japanese population, but also observed in some Dutch patients, of mutations in the C5 molecule, such that binding of eculizumab and ravulizumab is impossible, and the agents are therefore ineffective. And this is called out for alternative C5 inhibitory agents, which are now in advanced stages of development. So what we've seen is an evolution of our goals of therapy in PNH into the modern era, and some of that's been driven by the EBMT response criteria that we see again here. But we've got to look at both the biological and clinical goals. And while control of intravascular hemolysis is prime in our treatment goals, extravascular hemolysis now becomes a legitimate target for attack of therapy, and ongoing maintenance of a thromboembolism-free state is extremely important. We now can look at not just improvement in hemoglobin, but potentially normalization of hemoglobin and lactate dehydrogenase. The reticulocyte count can be normalized, possibly, and breakthrough hemolysis is a potential target for therapeutic goals as well. Pegcetacoplan was the first inhibitor of the third component of complement, so that proximal part of the pathway that was shown to be effective in patients with PNH. This paper in the New England Journal of Medicine was from the Pegasus trial analysis, which is a randomized study of pegcetacoplan versus ongoing eculizumab in patients on eculizumab, but with persistent anemia. And in this case, it was a hemoglobin of less than 95 grams per litre. And you can see that there was a run-in period for a month in which both agents were administered, and the median hemoglobin arose from the 80s to the 110s and close to 120. And in patients who continued on pegcetacoplan in the randomized phase, that improvement in the hemoglobin was maintained, while the eculizumab patients dropped back to the hemoglobin levels that they had maintained prior to starting the study. Along the way, though, and after the publication of this paper, breakthrough hemolysis, breakthrough intravascular hemolysis has been seen, and may be seen in up to a quarter of patients on eculizumab and more recently ravulizumab, although it's not necessarily clinically important for an individual patient. One of the potential underlying mechanisms for this, other than C3 deposition making the cells attractive to the reticuloendothelial system, is the fact that the PNH clone size in patients on C3 inhibition usually rises to near 100%, and thus more cells are available for hemolytic episodes in the event of an uptick in terminal complement for whatever reason, a complement activating system, some pharmacokinetic failure of pegcetacoplan, or some other unknown factors yet to be determined. There are other agents on the way. Iptacopan is an oral inhibitor of factor B, one of the proximal controlling molecules of C3 activation. This was the phase 2 study in which iptacopan was added to eculizumab, but subsequently the randomized study was presented in untreated patients as well at the American Society of Hematology meeting as a late-breaking abstract last year, and confirmed the activity of this agent, which is heading down the regulatory pathway in many markets at the moment. It is an oral drug administered twice a day, and seems to be effective both in patients stable on C5 inhibition as well as those treatment-naive patients. Danicopan is another proximal inhibitor of this time factor D, the other proximal controlling molecule, also an oral agent, and has been studied as an add-on to eculizumab and ravulizumab, and again in those patients who start off with an anemic phenotype, that is with a hemoglobin in this case of under 105 grams per litre, there's an improvement in hemoglobin and biomarkers of hemolysis. So this is another treatment that is in development and on the way. This is danicopan, preceded by iptacopan. And this was the trial design for the danicopan studies. But there are many other agents being studied at various parts of the complement pathway. You can see some of them described here. There is a second-generation molecule after danicopan called vermicopan, which is currently in development as well. Danicopan needs to be given 3 times a day, so it's a little less convenient. There are reasons to try and optimize the delivery of the oral medications as well, but you can see where pegcetacoplan is in the pathway, and as well as iptacopan, but there are multiple other agents, including C5 biosimilars, C3 convertase inhibitors, C5 convertase inhibitors, and some further inhibitors of factor B and factor B and factor D, that are in development using alternative mechanisms of delivery, such as RNA inhibitory molecules that may have an extremely long activity if found to be effective in clinical trials. Some of the alternative C5 inhibitors target different binding sites on the C5 molecule and will be of use in patients with C5 mutations, as I described in the Japanese and Dutch patients so far identified. Just a small advertisement for registries in ultra-rare disease. There has been an existing Alexion-funded registry which is focused on patients treated with eculizumab. With the development of new therapies and the expanding pool of treatments, it's important that we have a single registry in this ultra-rare disease. And so the International PNH Interest Group has developed and is moving towards activating a global registry which will be open to all patients with PNH across the world, independent of what they're treated with or whether they're treated at all. This will be obviously much simpler for the sites, and in fact the sponsors of the products available and in development have been enthusiastic about assisting the process. There will be a core registry with all of the essential data, and then silos for each individual company where their own product-specific data can be kept, which will meet their regulatory reporting requirements and also give additional data for analysis relating to individual products. As patients move from one product to another, they can move between silos, but their core data remains in the same place. So this is an academic registry supported by industry, but with industry advising rather than running the show. I'm pleased to say that there is an agreement with Alexion that the thousands of patients whose data are in the existing registry will move into this global academic registry. The committee of which I'm proud to chair. The other thing I'm very proud of is that we have engaged patient advocates in every stage of the development of this new registry, including the development of the questions that are being asked in the registry data submission forms, as well as analytic questions and very strong input into the development of the patient-reported outcome questionnaire, which will be central to the registry as well. So I'd like to conclude by just summarizing a couple of things. Therapeutic endpoints in any disease, but none more so than in PNH, are important to assess any treatment effects. One has to know what one is aiming for in any given therapeutic environment. The control of intravascular hemolysis in PNH is central and is the most important factor, however you achieve that, because that is the direct cause of excess mortality in this disease, along with important morbidities. Hemoglobin levels are important. They're not the only parameter of success in the effective management of this condition, but they become increasingly important, particularly in patients with who have developed extravascular hemolysis, which may produce clinical issues in some of these patients requiring separate management of some kind or another. And we have ongoing challenges in the future, and one of them is establishing guidelines, response criteria, and ensuring that our data acquisition in the real world is as comprehensive as possible. And I think the IPIC registry will be very important in helping us meet some of these challenges as new therapies appear. We do need to think about long-term safety with the newer agents, particularly most of them being proximal inhibitors. I've put infectious, autoimmune, and malignant possible risks there, given what we know about the excess of these in patients with congenital deficiencies of proximal complement components. The treatment algorithm requires establishment and definition, as do response criteria and management guidelines, and these are currently being worked on by a number of working committees within the International PNH Interest Group, or IPIG. And one of the questions that we will need to ask is whether combination therapy is better than monotherapy, and whether proximal inhibitors can live on their own in this environment. So I thank you for your attention. I thank the Academy for asking me to give this talk, and I'm more than happy to answer any questions you may have from me resulting from this talk or about PNH in general at my email address, which is there. I'd also encourage you to have a look at the PNH Interest Group at its website there. Join it if you have an interest, and come along to the Friday meeting of members at ASH, at the American Society of Hematology meeting, which is the annual event that IPIG has always run in addition to the scientific conference that was very successfully run this year in Harrogate in the UK in May. Thank you all for being with me on at least this part of the fascinating journey.